faculties, respected speaker, dear doctors, and all participants, warm greetings and a very good evening to all the joiners, and also a good noon to UK joiners. On behalf of Radiant Pharmaceutical Limited, I, Dr. Javed Saban, would like to welcome you all for joining today's a very interesting scientific webinar session on clinical decision making, applying clinical reasoning. You know that clinical reasoning is the thinking and decision making process associated with the clinical practice, and it involves patterns recognition, knowledge application, intuition, and probabilities, and it is the integral to clinical competency and is gaining more and increasing more attention within the medical community and medical education programs. In this context, this scientific webinar session has been arranged to focus a more holistic discussion and to provide a perspective on assessing the clinical reasoning by exploring current thinking and the strategy at all level of physicians. So today we have with us joined Dr. Nicola from UK as a keynote speaker. Dr. Copper is the consultant physician and clinical associate professor, Royal Derby Hospital, United Kingdom, and she is the author of Clinical Decision Making chapter of Davidson Principle and Practice of Medicine. Please welcome her. Please welcome Dr. Nicola. Very warm welcome. I would like to introduce today's special guest, Professor Dr. Tito Mia, Principal Mugda General Hospital, Dhaka, and also Dr. Raihan Rabbani, Consultant Internal Medicine and ICU Square Hospital Limited, Dhaka. And also like to introduce today's organizing panel, Dr. Latif Ryan Rahman, Registrar Internal Medicine, Leicester Royal Infirmary, UK, Dr. A.M. Anam as a consultant critical care and COVID unit Square Hospital, and Dr. Shihan M.R. Hawk as a consultant ICU and COVID unit of Square Hospital. So once again, welcome you all. The session will be moderated by Dr. Latif Raihan Rahman. So before going to our session, and I would like to thank specially all the respective individual of Academic Forum of Acute Care Physician, that is AFACP, for taking this great initiative and giving us opportunity to be the scientific part of today's session. So before going to our main session, I would request Dr. Raihan Rabbani to have an introductory speech on Academic Forum for Acute Care Physician. Dr. Raihan Rabbani, please. Can you hear Dr. Raihan Rabbani?
Thank you. Yeah, thank you, Dr. Javed. First, I like to welcome Dr. Nicola Cooper. We are very delighted to have her with us. And from Bangladesh, the acute medicine is a new subject to us. And as you know that everyone in the world, every physician does almost the same thing, same work everywhere. But organizing the systems are a little different from country to country and from continent to continent. So in India and Bangladesh, we used to follow the footsteps of British system. So that you know that we followed the British system for long, and members of Royal College and fellows of Royal College, they guided us for long in Bangladesh also. So nowadays, the acute medicine is getting some importance in Bangladesh also. So the hospital systems, the way the hospital runs, the way we are dealing with technology and everything, rapid diagnosis, concentrating on more acute patients. So all these now demands a separate department that will be in between the emergency, ICU, and the floor patients. So I think at that point, the evolvement of the new subject of acute care medicine is very timely and very demanding. So that will help us to organize and serve the patients more and more. So in this context, we are very happy to organize some academic sessions, and we also organized an academic forum for acute care physicians in Bangladesh. So our aim is to promote this subject, acute medicine in Bangladesh, and also we would like to promote it to that extent so that we can have a certification course and diplomas and degrees in and the say in Bangladesh is that you have to go through that son by the number of the edition. Like if it is a 37th edition, you have to read it 37 times to get your
Thank you, everyone. Dr. Latif Rahman is going to keep an eye on any technical problem we have. So thank you very much for inviting me. I am a consultant in acute medicine in the UK. I actually trained in internal medicine and geriatric medicine and also in intensive care for a while because acute medicine didn't exist younger. And it's very acute, very sick patients, but a lot of the time it is making a plan. I research it, in particular how to teach it as well. And I'm chair of a group in the UK called Clinical Group, a little bit about later. But for this session, I have moments where we can pause to discuss. But for the overview of what clinical reasoning is and a few things that we know about it. So as has Shell, clinical reasoning is the thinking and decision-making processes. Definition here, we're not sure if it's a skill, a process, or an outcome, but it's where clinicians observe, collect, interpret data to diagnose and treat patients. And it involves both conscious and unconscious cognitive operation. So that's the more formal definition. And how doctors literature from the education literature, and it's very difficult for an ordinary doctor or an ordinary teacher to access some of this literature because it's basically everywhere. Invisibility or in training over weeks in an outpatient clinic. And why does it matter? Well, there's been diagnostic error. We estimate, and figures vary, 10 to 15% of the time. And we know that diagnostic errors are the most serious of medical mistakes. They're more likely to result in death or serious disability, even compared with surgeon errors. And that undiagnosed disease, which could have been treated in life, has been the result of death in 10 to 20% of cases. USA, that's been somewhere between 40 to 80,000. Error is now the leading source. About diagnosis and this. The first one on the left, by the Academy of Medicine Institute, their first started the worldwide patient safety movement. So things like checklists before surgery, and really focusing on system safety. In this report, they talk about diagnosis, improving the diagnosis, but it's a moral, professional, and public health imperative. And they call on it based on evidence from the learning science talk. There's a lot of evidence about what strategies we can best use to teach. This report on the right is from the World Health Organization and the World Health Organization. So that diagnostic happen, and interestingly, or not, researchers have typically there are several root causes. It's multiple system failures. So system failures contribute to diagnostic error in one study in 65. There are also no-fault errors. So, for example, the case may have been so obscure nobody could have diagnosed it, or the patient may have presented late, that kind of thing. Factors, we know that human in error in general, and human factors training is mandatory in aviation throughout the world. It's in healthcare and in postgraduate programs in the UK, for example. But what most is that is thinking. or so-called cognitive errors, have been found to be a major cause of diagnostic error. This is a real interest, an explosion of interest and research in of diagnostic error from an educational point of view. And that's really what I want to talk about today, thinking that are a cause of diagnostic error, which is really now by of interest across 5 tertiary hospitals in the USA, 90 involving serious injury, and 33 deaths. 6 root causes, reasons why the error occurred. But they found the most common contributor to diagnostic error. And what they mean by that is that the doctor had all the information available to make the right diagnosis, but then made the wrong diagnosis. Faulty synthesis of the available information. Also, failure to judge the salient findings and other bias. Said was that faulty or inadequate knowledge, but things like premature closure, etc., were the most common causes of diagnosis. This was published. The idea that diagnostic error, a leading cause of preventable harm, was due to cognitive errors as opposed to inadequate knowledge or skills. This really started to move among medical educators to thinking processes involved in diagnosis. So that was 2005. But 10 years later of research, it turned out that teaching the general thinking skills involved in diagnosis didn't make a difference. So other researchers had this to say, this opinion that diagnostic error is a cognitive processing error is incorrect. Incomplete knowledge experience. There's good evidence to support this view. I hope you'll see as we go along that they're both right. Knowledge is definitely a prerequisite for correct diagnosis, but how we think matters as well. So, a review of the evidence so far is that knowledge is the key determinant of diagnostic accuracy. Courses that teach general thinking skills, whether it's critical thinking or teaching you about cognitive biases so you can avoid them, they've not been shown to be effective to date. But specific teaching strategies that are aimed at building knowledge and understanding, and they're very specific teaching strategies, not usual teaching, they do in studies lead to improvements. And there's something about reflection though. There's been even a meta-analysis published on reflective strategies during decision making, which shows it leads to improvements in diagnostic ability. And there's a debate about why reflection works, which is a complicated debate, which we might talk about later. Now, this poses a question, and I'll stop in a minute, but this poses a question for me: what do we mean by knowledge? Just education point of view, that we don't mean facts. We don't only mean facts. This is a revision of Bloom's taxonomy, which some of you may have heard of. But in terms of knowledge, there is factual knowledge, basic elements that students must know. But when we say knowledge, actual knowledge, procedural knowledge, how to go about something called metacognitive knowledge, which is knowledge about your own thinking, knowledge about your own don't know, and being able to think about your own thinking. And that is an important form of knowledge that actually is very important, which we'll come to a bit later. So whenever I say knowledge, I mean both formal and experiential knowledge of medicine, but also procedural and metacognitive knowledge, not just book knowledge. Now, as I mentioned, I'm called CREAM, Clinical Reasoning and Medical Education Group. We represent over half of the medical schools in the UK. And we've recently got together to try and think about patient accepted any day, which I'll share with you when it comes out, but areas for clinical reasoning specific education. And while medical schools and postgraduate training programs teach the basic elements of diagnosis, history, differential diagnosis, a lot of the things that are very specific picked up invisibly, implicitly. And as I said, there's a consensus that diagnosis education should be explicit, systematic, and based on evidence from the learning sciences. So what I wanted to do in this next bit is just go through each of these 5 areas and just give one brief example to get you thinking about your own teaching and your own learning. But at this point, before I go into that, I'll pause to ask you if anyone has any comments or any questions.
Dr. Cooper, if I may ask a question, that's all right.
Sure.
Yeah. So in terms of when we say knowledge incorporates a hierarchy of things, including to the metacognitive knowledge, would you then say that knowledge automatically incorporates the thinking process as well, and does thinking process being part of knowledge plays a part in diagnosis? Right. Okay.
Thank you. So later on, I'm going to show you that a person's individual thinking dispositions is extremely important in rational decision making, but it's independent of knowledge and IQ. Metacognition is when I'll give you a very simple example. You've probably met some doctors and some students who are very curious and who question, who eyes, they may be more healthily skeptical of other people's diagnoses. Metacognition is when you ask to stop yourself a question, or you ask yourself, how do I know that I actually know that to be true? I'll give you some examples to stand outside of yourself and observe your own thing, and what you don't know. And it is taught in primary schools and schools in the UK. And there's lots of good evidence from education that it really matters in terms of becoming an expert.
Okay. And in terms of the time pressured world that we live in, where we always are working against, that often is the challenge, where we whether we can, in that a limited period of time, synthesize all the information available to us in reaching a correct diagnosis. Would that form part of the knowledge as well, like the ability to work against time in extracting the relevant information in order to reach a correct diagnosis?
So time pressure is so first of all, correct diagnosis is associated with spending less time on a task. I'll show you some later. But time can in cutting corners and not gathering information, etc. But just stopping to engage in reflection can be very quick. It can be as simple as, what's the evidence for this diagnosis? What else could it be? Without a doubt, cognitive overload, time does impact our decision making, and that's what human factors is all about. It's the science of the limitations of human performance.
May I ask a question?
Yes.
Dr. Style of cognitive thinking and person-to-person variation and all those, and those are independent of IQ and knowledge. So if I put it like this, that some type of thinkers are like better poets, some are better artists, and is there a type who would be better physicians rather than better astronomer or better jet pilot fighters? So if that's the case, whether we should identify those persons and only allow them to come to be a physician or not?
That is a wonderful question, and we will explore that a bit later. But that is the research that I'd love to do, and that is the research that no one has done. What's interesting, though, if we were to select for people who tend to engage their reflective mind more, they may make great physicians, in particular maybe neurologists, but they might be terrible neurosurgeons. So we need a range of people in medicine, don't we? So it would be very difficult to select at medical school level, certainly, but no one's done that research.
Okay, thank you.
So, shall I carry on?
Please.
Yeah.
So, just going back to these 5 key areas, I'm just going to really briefly, I'm going to spend more time on the first one because it'll be most interesting, but just highlight some from numbers 2, 3, 4, 5. So clinical reasoning concepts. This is important for teachers and learners to have a shared understanding of what clinical reasoning is and to have a shared vocabulary. Otherwise, you can't have meaningful conversation and meaningful learning. So the starting point is that we all need to understand some basic clinical reasoning concepts and have a shared language so that we can talk about it and learn together. So I'm just going to tell you about some of the research over the years, which hopefully you'll find quite interesting. So in the 70s, expertise in medicine was considered to be a general thinking skill. So experts were considered to have superior general thinking ability. And so researchers decided to study it. And this is quite a famous, in the clinical reasoning world, book called Medical Problem Solving. And what these researchers did was they videotaped experts and students seeing patients and making a diagnosis. What they found was, though, that there was no difference in the process between novices and experts. They both quickly came up with 1 or 2 diagnostic hypotheses which guided their search for further information. But what they found was the experts were more accurate because they knew more. However, they found that success in one problem was a poor predictor of success in another, even within the same specialty. So even experienced physicians, their performance varied markedly from case to case within their own specialty. Now, this may seem obvious to us now, but at the time this was very groundbreaking, and they basically concluded that 2 of the most important determinants of competence in terms of diagnosis are information, i.e. knowledge, and experience. So researchers decided to look elsewhere. They started to look at knowledge and how knowledge is organized in the minds of experts. Now, one of the questions they had was, do experts have bigger memories? If you're a junior doctor, you probably think that consultants and professors have huge memories because they can just recite facts or remember cases, which of course students find very difficult to do. But when they did research on this, they found that given unlimited time, novices can remember as much as experts about a case on paper. But experts appear to acquire knowledge much more efficiently. They pay attention to much more critical information, and they ignore irrelevant details. You've probably seen this in action. Now, the reason there's a chessboard here is because there was a very famous experiment conducted in the 70s. And bear with me because there is a reason I'm telling you about this experiment. So Chase and Simon, two psychologists, took chess grandmasters and novices, and they showed them roughly 25 pieces of chess pieces on a board, set up as if in the middle of a game. They gave them only 5 seconds to look at it, and then they covered it up, and they asked everybody to recreate the chessboard as best they could. What they found was that the chess grandmasters could recreate almost the entire board, about 20 pieces, but the novices could only remember about 4 or 5 pieces. But the very clever thing about this experiment was that they repeated it, but this time they randomly distributed the chess pieces on the board. And they again showed the grandmasters and the novices for 5 seconds. And guess what happened? This time the grandmasters were the same as everyone else. They were hopeless. They could only remember the position of 4 or 5 pieces on the board. So why did this happen? Well, the answer is that years of formal study, experience, reflection in playing chess means that when a grandmaster looks at a chessboard as if in the middle of a game, they don't see individual pieces. They see a whole pattern, like individual letters in a word. They just see the whole word. Whereas a novice will just see individual pieces. In other words, in experts, knowledge is stored differently as patterns. And in those days, psychologists called it chunking of information. So when a grandmaster looks at the chessboard, it has meaning. And that's why they could remember almost exactly all the different pieces, because it had meaning. In medicine, we call this pattern recognition. We call it illness scripts. We have a very rich, in our long-term memory, individual pieces of information are stored as whole chunks. And that's the reason why experts appear to know so much. They can overcome the limitations of working memory by chunking information. And in fact, pattern recognition is what we use in our everyday life. So if I asked you which is the cat and which is the dog, there's no thinking involved at all. However, the medical student who may not have seen many cats and dogs will spend a long time trying to decide which is which. They may even get distracted by the chain around the dog's neck, wondering about the significance of that. But both of these animals have fur, both have 4 legs, both have pointy ears, both have wet noses, both have tails. But let's imagine the cat meows. Then the medical student will know that's a cat. And that's why novices get distracted by irrelevant details. Experts stand back and see the big picture. So pattern recognition is how we make decisions in our everyday lives. And we know, in fact, now that the human brain has 2 systems that drive thinking and decision making. And this is called dual process theory, which you may have heard of. So this is supported by functional MRI as well as many experiments in cognitive psychology. We have an intuitive, pattern recognizing, automatic and subconscious way of making decisions in life and in medicine. this conserves cognitive energy. It's highly accurate when experts use it, but it's also vulnerable to error. We also have a system 2, which is more analytical, systematic. It's conscious, it uses working memory. The two operate simultaneously, independently. They may be on a continuum. It's not either or. When something has been learned enough so that it can become automatic, it defaults to system 1. So just think about driving your car. Imagine if you had to drive your car every day as if in your first driving lesson. The cognitive effort involved would be huge, and we can't go through life that way. Once something has become learned, it's a remarkable ability of the human brain to relegate it to autopilot. And so that's what we mean by thinking without thinking. Now, just moving on from that, I'd like you, some of you have probably seen this if you've read the Davidson's chapter, but if I ask people to solve this problem using their intuition, not to think about it too much, over half of college students, when asked this question, will say the answer is 10p. And that's intuitive, it feels right, but it's very wrong. The answer is 5p. This is pattern recognition gone wrong. And that's what pattern recognition gone wrong. Subconscious or interpretation of information. You may have heard of things called anchoring, premature closure, confirmation bias, etc. Humans are basically cognitive misers. That's a psychology term. We will always default to conserving cognitive energy. And from an evolutionary point of view, that makes sense, because in ancient times, speed of decision making was often more important than accuracy. But of course, in medicine, this can cause us to make mistakes. And Pat Croskery, who's an emergency medicine physician and professor who writes a lot about cognitive biases, he talks about bias is a normal operating characteristic of the human brain. Biases are everywhere. They have the potential to influence almost every decision we make. Now, biases in psychology just means shortcut. And of course, biases are not always a bad thing. I would hope if this was me and my cardiac monitor did this, you would take a shortcut and not take a history and examine me before you decided what to do. So pattern recognition, what's called heuristics in the psychology literature, and biases, they're shortcuts. And in the psychology literature, they're neither good nor bad. Biases as pattern recognition gone wrong. We know from research that correct diagnosis is actually associated with spending less time on a task. So that implies that pattern recognition is good. And we know that that's what experts use most of the time. However, we also know that when the case is more complex, reflection during decision making improves performance. And when I mean complex, I mean relative to the clinician. And as I mentioned, it doesn't mean you have to take a lot more time. It can be simple as asking yourself, and in fact, medical students got them to ask themselves, what's the evidence for this diagnosis? What else could it be? And just getting medical students to do that improved their diagnostic performance, not but other cases later. So what I've covered there is sometimes called script theory and dual process theory. Reflection is interesting. We're going to come on to that later. But there's just a few clinical reasoning concepts, and this is about those.
Cooper, again, a quick question. So, as we say, experts in medical science are prone to prone to make diagnosis based on pattern recognition, and they're really good in it. So, is there a risk that if you're really good in pattern recognition, and is there a risk that if you're dealing with an uncommon condition which would require more thinking than our usual day-to-day cases, this might lead to an error in the diagnosis?
Yes. So what's really interesting is a researcher called Anders Ericsson, and he's an expert on experts. And he's written about the acquisition and maintenance of expertise in medicine, the name of the paper. He talks about the fact that once you can do something automatically, you stop putting effort in. And that's when your performance can actually start to go down. So there's some good evidence for this. To become an expert in anything, but especially medicine, you have to do something called deliberate practice, purposeful practice. Effort has to be put in. And sometimes when we become very good, we stop putting effort in because we no longer need to. And the danger then is that we can slip into not engaging our reflective mind and falling into those errors of thinking where we think we know what it is because we think we've got all the experience. Does that make sense?
It does.
Dr. Cooper, if I may ask you one question. Does pattern recognition among the general physicians or general medicine ones and specialized vary in outcome?
Right. That research, as far as I know, clinical reasoning is in internal medicine. A lot of it is being done on medical students, but no one has looked at, for example, if it's a respiratory condition, are the respiratory physicians better than the general physicians at diagnosing that problem? What we do know is that expertise is content specific. So clinical reasoning is content and context specific. And like I said, those experts varied markedly in their performance from case to case, even within the specialty of internal medicine. So, for example, what I have a particular interest in dizziness. Long story. I used to run a dizzy clinic. And so if anybody comes to our assessment unit with vertigo, I have a lot of expertise in making a diagnosis based on the history and the physical exam. But my other colleagues don't have that expertise, and they will often misdiagnose a stroke, for example. So it isn't so much about being an internal medicine physician or a specialist. It's more about your problem-specific knowledge of each individual presentation.
Thank you.
And one of the things I like to promote in acute medicine in the UK is that we should be really good at the common things that we see. Shall I move on? Any more questions?
No question.
Okay. I'll move on to the next bit, and I'll just really briefly give you some examples, because in medical school, we know that we teach history, physical exam, differential diagnosis. But if we were to look at what we teach in medical school and what we teach in postgraduate training programs through a clinical reasoning lens, then some of the things we would emphasize more that we don't necessarily emphasize now. There are also some specific teaching strategies that I've not talked about today that improve your clinical reasoning ability more than usual teaching. And maybe that's something we can talk about another time. But let's just talk about history and physical examination. What specific knowledge, skills, and behaviours do we need from a clinical reasoning point of view? Now, I'm sure some of you have seen this example because it's in chapter 1 of Davidson's, but in the neurology chapter of Davidson's, this is the 23rd edition, this is what it has to say about meningitis. So let's imagine you're a brand new doctor, you go to see a patient, maybe it's a 30-year-old woman with a gradual onset headache and a fever of 38, something like that. You have to make a decision. You have to make a decision about whether to perform a lumbar puncture. Now, if this is what you've been taught at medical school, you might think you might think that everybody who presents with meningitis has neck stiffness, right? So meningitis presents with a characteristic combination of fever, headache, and meningism. That's a medical triad. And meningism is photophobia, neck stiffness, and often things like Koenig's and Brudzinski's. So I've met many junior doctors in the UK who believe this. The problem is that this is not true. At least it's not true in the UK and the USA, where we have, for example, vaccines for bacterial meningitis, and people access healthcare early. So this is a study from the US where they looked at 300 patients prospectively coming into the emergency department with possible meningitis, such that they went on to have a lumbar puncture. So unselected adults. For brevity, I'm just including the signs. And what's interesting here, I hope you can see, is that there isn't any difference between patients with and without meningitis, but only a third of patients have neck stiffness on examination. This is true of my clinical practice in the UK. Patients with meningitis, even bacterial meningitis, commonly present with no neck stiffness on clinical examination. And as you can see, Koenig's and Brudzinski's signs are only in about 5% of patients. If something is equally likely to be in patients with a disease and without a disease, that means the likelihood ratio is 1. A likelihood ratio is the probability of finding something in patients with the disease over the probability of finding that in patients without the disease. So a likelihood ratio of 1 means it does not change your prior thinking. So if I see a patient with a gradual onset headache and fever, very bad global headache and high fever, no other explanation whatsoever, I will do a lumbar puncture. But many of my junior doctors will not. Now, I'm talking about this because I want to introduce this idea of what I call evidence-based history and physical exam. Because the problem is that although we teach prototypal presentations of common diseases at medical school, this has to become much more sophisticated as we become more senior students and as we become doctors. What's interesting is that in studies, when students are taught what percentage of patients present with certain features rather than just lists of features, they're better at diagnosis. They're even better if they're taught the basic science mechanisms of symptoms and signs as well. So, for example, only patients with a severe meningeal inflammation will present with bedside signs of meningism. In that study, it was people with more than 1,000 white cells in their CSF were the ones that tended to have neck stiffness. And there's a lovely paper called The Perils of Teaching Medical Triads, which says teaching medical triads may encourage superficial pattern recognition, that results in overconfidence and premature closure. Now, I don't know if you know about the JAMA Rational Clinical Examination Series, the Journal of the American Medical Association. And Stephen McGee is a US general physician who's written evidence-based physical exam. But you won't find evidence-based history and physical exam in textbooks. And so we need to find a way in our teaching to move beyond the textbook and start talking about the usefulness of signs, the probability of signs. Patients don't present like textbooks do. And it's this evidence-based history and physical exam knowledge that's important when it comes to judging whether someone is likely to have a disease or not, and therefore to order particular investigations or not. So that's just one clinical reasoning concept called evidence-based history and physical exam. I'll pause there if there's any questions about that.
Dr. Cooper again. And so not particularly a question, but in general, and like want to share my experience working as a doctor in the acute take. We often deal with patients who present relatively early when they don't obviously have the classical characteristic conditions which they may have, of the life-threatening conditions they may have, for example, a PE or a subarachnoid hemorrhage. So I feel as a doctor that the perks of seeing them early on in their disease process, for example, I may be seeing them in an ambulatory care setting, is that they often do not have the characteristic signs which characterize their life-threatening condition. For example, I may see a PE patient who doesn't have any shortness of breath. I may see a PE patient who is not hypoxic. I may see a subarachnoid hemorrhage patient who's completely has GCS15 and has had his or her headache completely resolved now. I may see a bacterial meningitis patient whose white cell counts are normal, whose CRP may be normal. So the difficulty I often face in this sort of scenarios is because investigating them for that particular condition often poses a risk as well. For example, LP is not harmless. CTPA for PE would not be harmless. So then if we also do not have the classical signs to accompany their condition, what do we do in those sort of scenarios?
I'm so glad. I'm so glad that you mentioned those two conditions, because actually there is a lot of good there's a lot of good literature on both pulmonary embolism and subarachnoid hemorrhage. The problem is that our teaching is not good. So, for example, imagine we were working together in the same hospital. Hopefully, we would be able to have a conversation about the fact that the only sign in suspected PE, the only physical sign in suspected PE that is useful is the fact that a high fever has a negative likelihood ratio. So having normal oxygen levels, even a normal AA gradient, normal respiratory rate, normal heart rate is all compatible with the diagnosis of pulmonary embolism. But we just don't teach it, because in textbooks and at medical school, we're teaching prototypal barn door presentation diseases that no one could miss. Same with subarachnoid. The subarachnoid hemorrhages that come to medicine are the people who are well, with a GCS of 15, who may have had painkillers, whose headache has now gone away. Because the ones that have collapsed and have an obvious subarachnoid have gone straight to neurosurgery. So, but again, there is literature on the fact that many patients just present with that sudden onset, maximal within the first few minutes intensity headache and have no abnormal signs on examination. So there's good literature for those two conditions. I think it's all about our teaching. It's not that you're seeing people early, it's that you're seeing people how they present in the UK context. And that's what we should be teaching by the time you're a postgraduate trainee in acute medicine. Obviously, that poses the issue that your teachers need to know evidence-based history and physical examination as well.
Yeah, so what would be your advice to the junior doctors who are managing these patients? Should we have a very like low threshold for suspecting the life-threatening conditions and investigating more with more frequency, or like what would be the ideal approach? Because
so the ideal approach is to learn. So don't read textbooks. Read good review articles by experts. So we have a training day website, as you know. I'll let everyone know. It's called internalmedicineteaching.org. Internalmedicineteaching.org. And when we cover a particular topic with our acute medicine registrars, I will try and find a useful review article and I'll post it on the website. Because for example, our website has a nice review article on thunderclap headache. And an up-to-date review article by an expert writing in the same context as where you're practicing, you get a much more nuanced view of, out of 100 patients who present with this condition, these are the symptoms and signs they will have. Much better than a textbook, which will just tell you. Textbooks tell us medicine as it was practiced in the UK, 200 years ago, basically.
All right. And there's been another question from one of the panelists. In cases of signs or symptoms in reference to Kernig's or Bruggen's cysteine, which has a likelihood ratio of 1, meaning that they can't differentiate between a patient with meningitis or without meningitis, the question is there any importance of trying to elicit those signs? Should we just stop looking for those signs if they have a likelihood ratio of 1?
That's right. That's a good question. So we examine in things like the MRCP have no utility whatsoever, and we should probably stop teaching those things. Likelihood ratios refer to how an individual finding can shift our thinking, making a disease more likely or less likely. They don't tell us if someone has the disease, but just how they shift our thinking, if that makes sense. So if I see a patient with, a global severe headache with a fever, but there's no other explanation for that, no tonsillitis, no other illness, no pneumonia, then they will get a lumbar puncture. But that does not mean that I do a lumbar puncture every patient. It's that big picture of what I think the diagnosis is.
Yes, so if I understood correctly, if my initial suspicion is of meningitis, regardless of whether neck stiffness or Bruggen's cysteine or Kernig's sign is present or not, I should still do that.
That's right. So remember that as you're building your knowledge and expertise, you will get better at making a judgment of clinical probability. So you're dead right. If there's no other explanation for a gradual onset severe headache and fever, after a good history and examination, those patients would get a lumbar puncture.
May I ask a question actually? So, or more a discussion rather than a question. So we are talking about diagnosing cases. So there are many cases that we cannot diagnose, and there are many things that resolve naturally. So many complaints, if you give some time, it goes away. So whether we need to push and whether we need to push our students or trainees that you have to diagnose or not. Like in USA, as far as I remember, that pulmonary embolism, any patient with shortness of breath was going for CTPA, and it increased the rate of breast cancer in women. Repeated exposure to the radiation, and it increased that. So if we are putting patients like that into various investigations, that also has consequences. So if the patient is like having minor symptoms and we don't know the consequences of the disease and what the diagnosis will tell us, how to push, to what extent we should push for a diagnosis. So is there any comment about that?
Thank you. That's a really excellent question, because the two cases we talked about, pulmonary embolism, subarachnoid hemorrhage, and actually meningitis as well, they're examples of what's called rule out worst case scenario. So there are a certain number of cases where it could be something serious, and if we miss it, that could be even fatal. And that's very different to someone who may be complaining of something else. Even with the explosion of medical technology in the last 30 years, studies have shown that a history and physical exam leads to about up to 90% of diagnoses. These were studies done in outpatient settings in internal medicine. And here in the UK, we have a culture of really taking a good history, especially in geriatric medicine, where we will phone the care home to get an eyewitness account, and we'll talk to relatives to really get to the bottom of why this patient came to hospital. And the idea that, you know, we don't want to over investigate, because you're dead right, finding even incidental findings. So there are very clear, useful evidence-based guidelines in the case of pulmonary embolism. We use the PERC rule, then we may do a D-dimer, then we'll use the simplified PESI score to decide if someone's coming in or not. You don't get to have a CTPA just for breathlessness. You have to have gone through a process that at least is based on history, examination, and evidence before you get there. Because over investigation is another problem. You're dead right.
So can I comment something, or can I ask something regarding the the presentations of the meningitis you have mentioned? Before going for the lumbar puncture, yes, there are certain situations which mimic the meningitis, or may have the features of meningism without meningitis. So
Yep.
good history taking and examinations, we do agree this will help. Or can just like you have mentioned in case of pulmonary embolism, routinely patients should not be submitted for the CTPA. Rather, we can go for the other meticulous history taking examinations, and some less injurious, less invasive investigations or less injurious investigations may help us, like just you have mentioned in case of pulmonary embolism, like the D-dimer can give some clue to the evidence, good history taking examinations, and if the D-dimer is positive, the raised, then this may be a clue for going for the CTP and other things. And similarly, if we examine a patient, say a patient has got the enteric fever or rickettsia, having headache and having all the features like the meningism, the meningitis. So history taking examination and some investigations, say patients having rickettsia or enteric fever, having the neutropenia or the leukopenia in the blood pictures, and on the contrary, a patients having the meningitis, bacterial meningitis, having neutrophilic leukocytosis. So the minimum investigations, in addition to the history taking and examinations, may be helpful. This is to me. What do you think about this?
Yes, exactly that. And this is where that formal and experiential knowledge of medicine comes in, the pattern recognition. Because, you know, dengue fever can present with a terrible headache, but actually with experience and reading and study and mentorship, you know, we will learn not to LP people with dengue fever because it's not meningitis. On the other hand, hopefully we'll learn over time that some people present with even bacterial meningitis without necessarily having neck stiffness yet. It's hard to convey, isn't it? But that history and physical exam is so key. But what I wanted to really get across was that patients don't present like the textbooks say. Textbooks are telling us, you know, the very obvious late presentations ago, not necessarily how people present in different contexts now. And there's good literature out there that is not in textbooks that can help us understand how patients present nowadays with various conditions.
Definitely, the evidence-based history taking and the interpretations of the findings is definitely, rather I should say, it is better than the findings in the text. Yeah. Thank you.
So leading on from this is this other concept, which is about tests. Because the reason why evidence-based history and exam is so important is because we use that to make a judgment of clinical probability. So for example, if I see a 23-year-old woman with cardiac sounding chest pain, I know it's actually unlikely that she has ischemic heart disease, unless she has some very strange risk factor. Because ischemic heart disease doesn't really exist in 23-year-old women in the UK, unless maybe she had type 1 diabetes and smoked and had hypercholesterolemia or whatever. So we make a clinical judgment about clinical probability when we see a patient, and that's really key to interpreting tests. Now, I actually do that something else is true. So we actually use Bayesian reasoning or Bayes' theorem all the time in medicine. But when I ask my registrars, have you heard of Bayes' theorem? None of them have heard of it. But here's a very practical example. Imagine a 70-year-old woman has fallen and hurt her right hip. She's come to the emergency department. The right hip is extremely painful to move. She cannot weight bear at all. Does she have a fracture? Now imagine both the AP and the lateral X-ray is normal, and it's been reported by a musculoskeletal radiologist as no fracture. The question we're faced with as clinicians is there a fracture? Now, most of us appreciate that in a high clinical probability case, a normal test does not exclude the disease. But in a low clinical probability case, a normal test does exclude the disease. So, in other words, the interpretation of new information depends on what you believed beforehand. And that's basically what Bayes' theorem is. It's that the probability that someone actually has a disease depends on your clinical probability and the sensitivity and specificity of the test. Now, most of us implicitly pick this up in our training. And we know that you can miss hip fractures on a plain X-ray. About the sensitivity of a plain film in the emergency department for picking up a hip fracture is about 95%. That means 1 in 20 will be missed. But because we're not very explicit at talking about diagnostic tests, and I haven't got on to predictive values, prevalence of disease, and so on, this was a systematic review published in 2015 of several studies where they asked qualified health professionals about whether or not they thought someone had a disease based on the pre-test probability and the sensitivity and specificity of the test. And what they found was that universally, commonly used measures of test accuracy were poorly understood. The reason I mention this is because I've seen lots of misdiagnoses and harm caused by misunderstanding how to interpret tests, and I don't think it's something we teach very well. For example, we had a patient with a 50-year-old man with severe abdominal pain. He was in atrial fibrillation. The surgical resident decided that it could not be an ischemic bowel because his lactate was only 4. That's a really good example of misunderstanding how to interpret tests. If the clinical probability is high, in other words, a 50-year-old man in AF with an acute abdomen and nothing else to explain it, if the clinical probability is high, a lactate that's not very high is irrelevant. Another common example of strange diagnoses is I've seen many young women diagnosed with temporal arteritis. Temporal arteritis or giant cell arteritis, the prevalence in 25-year-old women is 0. So even if they come with a typical head over and their CRP is raised, it still cannot be temporal arteritis. So a basic understanding about prevalence, pre-test probability, and then how to interpret test results is absolutely vital in diagnostic accuracy. I'll pause there in case anyone has any comments on how we teach this at medical school and in postgraduate training programs.
Hi, Dr. Cooper. This is Mazabin. I'm one of the neurology trainees in Sheffield.
Hi.
I used to be an acute medicine trainee in East Midlands. I had attended many of your lectures. All of them were fantastic. Thank you.
Thank you.
My question is slightly different. So it's because we are talking about the diagnostic investigations. So we had a teaching a couple of weeks back about nowadays we talk about the fright of doing a lot of investigations because of the litigation possibilities. Now, when we think that our clinical reasoning is correct, even though in those cases we request a lot of tests, because we think that if we miss anything, that will cause a lot of litigation troubles. So my question is how we learn to balance to stick to our clinical reasoning versus our fright of having litigation or investigations in case we miss any important diagnosis. Thank you.
That's a really wonderful question. So there's been research done on GPs, family practitioners, which showed that the more knowledge and experience you gain, the less risk averse you tend to become. However, some people are always, because of their personality, more risk averse than others. So, for example, I tend to be very comfortable with risk. Some of my colleagues will do lots and lots of investigations, and we all tend to be slightly different, even if we all have the same knowledge and experience. I'll give you an example of how evidence-based history and exam and understanding tests can help not do things. We had a patient an elderly woman had fallen, and someone for some strange reason had done a highly sensitive troponin T. And one of my junior doctors came up to me and said, "Shall I start this patient on treatment for an acute coronary syndrome?" And he said, her ECG is normal. She didn't have chest pain, but her troponin is raised. It was significantly raised. It was moderately raised. And I like to get learners to engage their reflective mind. So I said, what do you think? I said something like, let's just think about this. What do you think the diagnosis is? What's the clinical probability of an acute coronary syndrome? And he thought about it and he said, well, she had no chest pain. Her ECG is normal. She had a fall. So I don't think it's an acute coronary syndrome. And I said, yes. And did you know that if you're over 75, you have a mild elevation in 50% of patients will have a mild elevation in their troponin just because of their age. And he said, I did not know that. So that's an example of, now for me, I was not going to treat that patient at all. I know some colleagues who then would, but there's a risk of harm from bleeding and so on. The clinical probability for me was very low of an acute coronary syndrome and so on. So that's a really good example where knowledge of how to interpret tests and a good history and exam stops you doing things to people, stops you doing further tests. But you're dead right. We will always vary in our aversion to risk, and that's a problem I don't know how to overcome.
Sure. Thank you. Thank you very much, Dr. Cooper.
Dr. Cooper, I may just share some of my experiences here as well, especially with regards to troponin. So sometimes we end up doing troponin in conditions we know troponin is going to be released anyway. For example, if somebody comes with a exacerbation of a known heart failure, but doesn't have any chest pain and doesn't have any like ECG change suggestive of ACS, somebody may still end up doing troponin I just to make sure that it wasn't an MI which led to the LVF on top of his CCF. But then the question that I struggle with is, what if its troponin comes back positive? Does that actually prove that it was the MI which led to the precipitation of AL on top of his CCF? So, so these are the middle ground conditions where we know a test is going to be positive, but we are not exactly sure what we are going to do with that positive test result.
So that's particularly a problem when we work in systems where someone else, the doctor, in healthcare systems where we have a 4-hour target to wait in A&E, patients are often met by a nurse practitioner. They use a protocol to order blood tests that may be inappropriate, and then an inexperienced doctor is having to interpret the test result. In our emergency department, we banned anybody apart from a senior doctor asking for a D-dimer. And the result of that was not only less D-dimers being sent, but a reduction in CTPAs, but no missed PEs. So there are some simple system things we can do maybe to reduce harm from unnecessary testing. Yeah. I'll move on, if it's okay, to just the next one, because we're near the end now. But this is very interesting. This particular thing called problem identification. It sounds a bit strange, but there's a lot of research on this. Now, in Graeber's study at the beginning, faulty synthesis of the available information was the most common cognitive factor involved in diagnostic error. Now, at medical school, we tend to teach history, examination, and then differential diagnosis. If I can persuade you to do one thing differently, please don't ask students for a differential diagnosis. You have to do something before then, and that is called the problem representation. And I'll explain why that matters. So the problem representation is how you mentally represent the problem in your head. And in psychology, there's actually I think the Cambridge Handbook of Problem Solving. So psychologists have really studied problem solving, and the first step in problem solving is to first identify there's a problem in the first place, but secondly, to represent the problem. And in medicine, we call that the problem representation. Of course, I'm a geriatrician as well, and our patients have problem lists because they have more than one problem. And in internal medicine, frequently patients have more than one problem. But let's just talk about a patient who comes with one thing. It's important to spend time really representing the problem using what's called semantic qualifiers and precise medical language. Semantic qualifiers are abstract binary words such as acute, chronic, bilateral, unilateral, intermittent, constant. They're these precise descriptors that we use in medicine. And also, we have to use very precise medical language when we represent the problem. Let me give you an example why this matters. We know that experts spend longer on doing the problem representation before they try solving the problem. Novices spend very little time doing a problem representation, and then they often then try and solve the wrong problem. Being able to do an accurate problem representation helps to organize and retrieve knowledge from long-term memory. And there's this paper here by Bordage demonstrates or mentions that, especially when the case is complex, accurately representing the problem is associated with 80% diagnostic accuracy compared to near zero diagnostic accuracy when this is not done. I'll give you a really simple example from medical students. Okay, a medical student went to see a patient, an elderly patient, and I asked him what his problem list was, and he said acute confusion, and he said raised creatinine. I then asked him what his plan was, and he really struggled to make a plan. So after a few minutes, I said, okay, let's stop, go back and tell me the problems again, but this time use precise medical language. And after a while, he said delirium, and then he said acute kidney injury, AKI. And then I said, right, what's your plan? And immediately he had a plan for each problem. I'll give you another example. When I'm teaching students, particularly junior medical students, we may have gone to see a patient and I ask them to represent the problem and they'll say chest pain. I'll say, okay, what do you think it could be? And they'll say the first thing that comes into their head from their memory to do with chest pain, they will say acute coronary syndrome. Except the patient we went to see was a 30-year-old woman with pleuritic chest pain and breathlessness. Now, when you get the students to say, this is a left-sided pleuritic chest pain and breathlessness in a 30-year-old woman, and then you ask them what they think the diagnosis might be, they will immediately come up with sensible things like pulmonary embolism, pneumonia, pneumothorax, whatever. So I do encourage you to try when you're teaching and when you're seeing patients to really represent the problem. It's just a succinct summary of the problem using precise medical terms before differential diagnosis. And when we're teaching students the differential diagnosis, there may just be one, but usually we encourage students to include a must not miss if relevant. But that has to come after the problem representation. So there's actually quite a lot of research on that, and I just thought I'd tell you about it because it's quite interesting. The other thing that's really interesting about problem identification and management is that we know that people who are high performers, they organize their knowledge differently in their heads. I'll just tell you about this lovely experiment. This experiment was done on fifth-year medical students. They each took a test at the start, and their knowledge was, they were divided into groups of equal knowledge, so their knowledge was the same at the beginning. They then asked them to solve problems, to solve cases. And one of the cases was a case of anemia. The high-performing students organized their knowledge differently to the low-performing students. So the low-performing students, when they were asked about anemia, they just talked about anemia in a very disorganized way. You've probably maybe seen that yourself when medical students just start telling you everything they know about something. But the high-performing students, they did something different. They said, okay, what is the mean cell volume? Right. If it's low, it could be this, and I'm going to do this. If it's normal, it could be this, I'm going to do this. If it's high, it could be this, and I'm going to do this. So high performers in terms of diagnosis, they have a sort of decision tree in their head. They have what's called organized problem-specific knowledge. And we know from other research that knowledge organization is actually key to expertise in diagnosis and in medicine. And because clinical reasoning is very context-specific as well as content-specific, having organized problem-specific knowledge helps you apply that knowledge to different cases in different contexts. In psychology, that's called spontaneous analogical transfer. So having organized problem-specific knowledge helps you move from case to case and apply what you know in different contexts. So that's another interesting thing about problem identification and management. And then the last thing to say about problem identification and management is, remember I talked about reflection. So diagnosis, remember, relies on these two distinct processes, system 1 and system 2, or type 1 and type 2. So we have what psychologists call the autonomous mind. That's our fast, intuitive way of making decisions. We also have what psychologists call the algorithmic mind. So that's our deliberate thinking things through using working memory. But recently, psychologists have identified a subset of system 2 called the reflective mind. And this particular psychologist, Stanovich, they've published on this. What they found, and there's lots of research to support this, what they found is that people vary considerably in how well they make decisions. But the largest differences are not explained by IQ or even knowledge. The largest differences are explained by people's tendency to seek information, to look for evidence, to analyze, to weigh things up, to be healthily skeptical, to be aware of context, and to think about their own thinking. And so they call this tri-process theory. Remember, I talked about dual process theory in the beginning. And so while knowledge is absolutely vital for making decisions, there's something else that accounts for a wide variation in good decision making. And basically, there's this idea that the reflective mind interrupts system 1 to simulate alternatives. Of course, to do that, you need knowledge. So there's a growing interest in what's called reflective strategies in diagnostic decision making, and whether it's a trait or a state, but many psychologists believe that we can teach it. And as I mentioned, metacognition is taught in schools. I'll just do one last thing and then we'll have general questions, but one last thing is shared decision making. And by that, we mean not just with the patient and carers. So if you're a general practitioner in the UK, shared decision making often means with the patient. But in clinical reasoning, shared decision making is using guidelines, scores, decision aids, using your iPhone with your team, and also what I call certain behaviours, optimal decision making behaviours. So civility, listening, clearly communicating at handover, and so on. And I don't know if any of you have heard of the Civility Saves Lives campaign. It's a thing in the UK right now that when people are rude, so that when the orthopedic surgeon is rude, not that I'm stereotyping in any way, it can be a patient safety issue. So those are the 5 components, really. And just to sum up what we've said, good clinical reasoning is not a general thinking ability. It used to be thought to be that many years ago, but we now know it isn't. It is highly dependent on knowledge, both formal and experiential knowledge of epidemiology, basic science, and clinical medicine. But remember, when we say knowledge, we don't just mean book knowledge, and that's really, really key. there's this thing called metacognitive knowledge in education, which is actually very important in learning and in developing expertise. And although knowledge matters, we also know that this tendency to engage in reflection and behaviours really matter as well in terms of how good you are at diagnosis and not only diagnosis but managing a patient. So that's all I have to say, really. And that was definitely, I know we seem to have been here for a while, but that was really a whirlwind tour of, decades of research, and we could go into it a lot more, but that's a whirlwind tour of clinical reasoning. And if you want to know a bit more, you can look at the ABC of clinical reasoning. You can get a free version of it online somewhere, I'm sure. But anyway, open for discussion.
Dr. Cooper, just a quick question on shared decision making. So obviously there is a culture in the UK and in a lot of countries I'm sure in the world that when you're dealing with a particular patient who falls under a particular specialty, no matter how confident you are in knowing what you you're doing what is right, there's always a tendency to get specialist advice from the specialist from the fear that you might face criticism if you did not involve the specialists. So is there a risk that in doing so, when you try to get advice from a specialist who obviously hasn't seen the patient and wouldn't know the patient as well as you do, there's a risk that in trying to get this shared decision, you end up reaching a wrong decision because you then follow a specialist advice, which is kind of misinformed because not all the communication, information may get across to them.
That's a really good point. I call this event runaway. So this is when a junior doctor has phoned a specialist who's not seen the patient, who's given bad advice. Everyone follows it because it was the specialist, but it wasn't appropriate for that patient at all. So listen, there are some conditions like stroke, GI bleed, respiratory failure that are very definitely best, the evidence shows, looked after by a specialist. The danger in internal medicine and acute medicine is that we will stop making decisions ourselves if we ask the specialist all the time. There are many situations, for example, in frail elderly patients, where we know, because we know the patient, what is and is not appropriate for them. So I do my best to make a decision myself when I feel it is within my competence. But if there's a national guideline that says I shouldn't, or if the patient really would benefit from specialist care, then I will leave the decision making to the specialist, if that makes sense. In where I work, we have what's called specialty in reach. So people with inflammatory bowel disease, decompensated liver disease, GI bleeds, we will allocate them to gastroenterology, and we will look after them together while they're on our unit, and then they'll go to the ward. So that really helps us learn continually, as well as the patient getting best care. I teach my junior doctors to filter everything through their own brain. So whenever they're given advice from a specialist, they need to stop and not follow it blindly, but to consider whether it's appropriate for their patient that they know. I think that's very important.
Good afternoon, Dr. Cooper, for your nice and informative presentation. I have a question. How much impact of ethical decision making on clinical decision making? I mean, do I have to give more priority to ethics whenever I'm making the clinical decision making, or should I continue as a regular basis?
Can you repeat the question?
Yeah, my question is, what is the impact of ethical decision making on clinical decision making?
Yes, that's a really good question. So I think back at the beginning, although it was just brief, I showed the slide about context and how the environment, context and culture affects our decision making. And there were a lot of factors there. So, for example, the patient's culture, time, staffing, etc., etc. Clinical decision making is yes, knowledge is important, but actually, as we become more expert in medicine, there's something else, and that's what some people call wisdom. And we don't talk to our trainees much about this, but actually, the practice of medicine is also about developing the wise doctor, and that is something different, isn't it? We make decisions in the best interests of our patients. Many of those decisions are legal and ethical decisions. In the UK, we have quite a structured ethical framework, so it's easy to know what to do in a situation. But you're dead right. Just because we can do something doesn't mean we should, or doesn't mean it's best for the patient. And that's a higher level of decision making. It's beyond being a trainee. That's being a real expert, and that's being what's called a wise doctor, and that's very important.
Thank you for the answer. Thank you.
So I have a question. So when I was trained about 15 years back, there was a very popular term, multitasking. So, and when I was multitasking, I found it very difficult for me. I used to concentrate on one topic and then solve that, then go to another one. So while I was trying to manage multitasking, I failed. So I gave it up and I stood in my way, how I did it. I managed okay with that, with my way. So any comment or any research on that, whether multitasking is good or whether it's fit for a specific type of people or not? Dr. Cooper, please.
So what you've alluded to there is human factors. That's the science of the limitations of human performance. In the ABC of clinical reasoning, there's a chapter on human factors. We know that decision density, interruptions, cognitive overload, all those things impair human thinking and decision making. And particularly in places like the emergency department and in theatres, human factors training and awareness is quite common now. So you're dead right. In human factors training in the UK, we teach people to be aware of situations and contexts that can affect their decision making, so they can take steps to mitigate those, which sounds exactly what you did. You improved your decision making by changing your strategy. So yeah, that's all about human factors, which we haven't really talked about.
Yes, Cooper. May I ask one question regarding mentorship? Yeah. In the last slides, you have mentioned about the sharing decisions. And Latif has asked one question, either should we take the decision from a person and from one colleague who does not really seeing the patients. So this may sometimes misinterpret or sometimes error in the diagnosis or in making the decisions. But nowadays we are listening about the e-mentoring or virtual mentoring for some trainees. Say, does it really influence in making the decisions on virtual mentoring or sharing decisions, virtual sharing decisions? Is there any role of this in interpreting, in taking decisions?
Yeah, so that's really interesting. There's actually quite a lot of work which may be related. So there's a man called Eric Holmboe who works with the American Medical Association. He's basically the man who invented work-based assessments, case-based discussion, clinical evaluation exercises, that kind of thing. And he's written some lovely paper about how faculty do not observe trainees. So basically what he's saying is that it's well documented that students and trainees have deficiencies in their history taking and physical examination skills. But because they're never observed by their teachers, those deficiencies are not picked up. What happens then is that the trainee, for example, comes to tell the teacher what they found. The teacher just believes it at face value because the teacher didn't observe. And that then leads to problems and the wrong diagnosis. So the problem, of course, is that we don't have enough experienced physicians who have the time to observe. A lot of time we are taking trust what our trainees have said to us, whereas actually they may have completely missed something very important. And that's the problem with that's one of the problems together, especially when that trainee is just starting out on their specialty training. Yeah.
Dr. Cooper, if I may just ask, obviously in this, like when the COVID arrived, a lot of the specialties started doing virtual clinics where they stopped seeing patients and started discussing them over telephone or over like over virtual platforms. Would you think that posed a risk of leading to inappropriate clinical judgments? Like, how was the experience overall during this COVID crisis?
Good question. Well, no, I think people are actually researching that at the moment. I mean, a good service would hopefully decide based on what they're hearing over the phone or seeing over the video. They would be able to decide whether someone needs to be seen face to face. And I think that's what our family practitioners have been doing in the UK. But I have seen we've been seeing some very inappropriate referrals to hospital. The GP and you know, the GP got the wrong end of the story, you know. But it's difficult. We don't know what the impact virtual consultations are being on decision making. It contributes the most to diagnosis, and hopefully in the hands of a good doctor, they would be able to judge based on highly how it would work, but it's difficult.
And one final question, if that's all right. Sorry, I keep on asking questions. So obviously, because I've worked in 2 different health systems, I know that what you can do for the patient would also depend on the facilities you have in your society, even within a particular country. So I've worked in my country, where I've worked in a government setting as well as a private sector, which is completely different to one another. Like, there are different things you can do for the patient. So would what you can do for the patient and what the facilities you have for the patient then have an impact on your clinical judgment? And would that affect patients' management? Like, for example, if you have a facility where you can get very quick echoes or very quick MRIs, and you are working in another facility where you don't have those, what are the impact that can have on the patient safety as well? Yeah,
absolutely. That's a really good question. So there's we didn't talk about management reasoning, but there's a paper by David Cook et al. 2019 called on management reasoning. And you're dead right. Clinical reasoning does not end with a diagnosis. But management reasoning is arguably more complex because there's patients' preferences, evidence-based, but as applied to that patient. There's the resources and local guidelines, local health context, all to take into account. And there may be, while there might be one diagnosis, there may be multiple management options, many of which are not possible or not appropriate for that patient. So management reasoning is beyond diagnosis, but a lot of the research on clinical reasoning has not been done in management because diagnosis is something you can measure, it's right or wrong. So research tends to be done and just stops at diagnosis. But you're absolutely correct. And when we're in the CREAM publication, we actually talk about that very thing. Management reasoning is more complex because there are multiple factors to take into account. Yeah.
So I want to ask another question. I go with Latif that I keep on asking questions. So nowadays that we see the research and the evidence, these are like very popular terms. And when I was like more younger, I would see a more analytic essay kind of reasoning in the textbook and everywhere. So the way I was taught is more analytic way. So those were done by more brilliant minds, and evidence was like a less important, little less important, not less important, little less important. But nowadays we are all talking about evidences. So in some cases, I'm seeing false evidences, not false, maybe misinterpreted, and not looking at the right point. And those are undermining rational reasoning. And also we are missing brilliant minds coming up with their ideas and analytic ideas that we can interpret in the clinical practice. So when we are talking about evidence, and we are looking at a lot of evidences, tons of evidences, and we are also confused which one to look at and which one to take and which one not to take. So how to deal with that, and how to like find out the right one? Who will do that? Not everyone has the capacity to do that. So whether there's any structure to interpret all those things in the human society. So any comment about that, Dr. Cooper, please?
So, I mean, I trained in geriatric medicine, and most of the evidence doesn't apply to anyone over the age of 70 because the trials have not been done in anyone over the age of 70, pretty much. And of course, older people are more likely to have side effects from medication. So I'll give you just a little example. A 91-year-old man with advanced dementia, an Indian man, was admitted to my hospital with an inferior ST elevation MI. He was whisked to the cath lab, and quite rightly, I think they decided not to do anything. And so he came to our acute medical unit. Now, the guideline says that he should have dual antiplatelet therapy, a massive dose of a statin, anticoagulation, and all of this. Now, he was just walking around the ward because he was completely well. And remember, it was an inferior myocardial infarction. It was small. He had no heart failure. He had advanced dementia. He was 91. And I just stopped everyone going mad. I just put him on aspirin and a beta blocker and sent him back to his home hospital, because on the basis that there's no evidence whatsoever for any other treatment in a patient like that. And, first do no harm. So you're right. There's, the definition of evidence-based medicine is evidence, but applied to the patient in front of you, not just their physical needs, but maybe also sometimes their psychological and spiritual needs as well. Some evidence is interpreted crazily. So, for example, mask wearing in indoor public spaces in the UK didn't happen for months and months and months during coronavirus because of no evidence. And if what we mean by evidence is a randomized controlled trial, that's just completely bonkers, isn't it? Because there are different types of evidence. So yes, rigid evidence-based medicine can be a problem. Yeah.
Dr. Cooper, I've got two interesting questions from the audience pool, if it's all right for me to just read them to you. So Dr. Farooq Shaheen raises an interesting question. So traditionally, there has been a tendency to get a spot diagnosis, right? Like seeing a patient and try to get the diagnosis spot at the very first consultation. So do you believe that there is a role for a spot diagnosis, and whether some clinicians are generally good in making them compared to others? And if that's so, what is it that makes them more confident than others in trying to get a spot diagnosis?
So, yeah, I mean, one of the reasons I love internal medicine is because it's so varied, yeah? So you can be in an outpatient and making a diagnosis over weeks because it's a blackout clinic. It was called the collapse dizzy clinic. So some of those blackouts and collapses were a bit difficult to get to the bottom of. But yes, on the other hand, you can see a patient and you can know straight away once you've seen them. And the people that are good at making a spot diagnosis are people with lots of knowledge and experience. Well, we know the evidence shows that it's experts that are good at just knowing. You know, have you ever had that experience where you struggled all night or all day with a case and you're confused, and the consultant walks in and just diagnoses it? Many of us have had that experience, and we don't know. We literally don't know how they did it.
Yeah,
and
I myself have had this experience with my two mentors here, Dr. Chitumia sir and Dr. Ranbrook sir. So
yeah, and even they struggle to explain to us how they know, and that's because it's actually tacit knowledge. It's that intuitive system one decision making that they're using. It's so subconscious that even they find it difficult to explain how they got there. But that's expertise.
Yeah. And the second interesting question is, and this is where this question I find it really interesting. So if you're dealing with somebody who happens to be a relative, a very close relative of one of your doctor colleague, how does that affect your clinical judgment? I know it's a tricky question, but is there any research on it? Or?
Yeah, that's a really beautiful question, and I'll tell you how I approach it.
So it's Alamgir who asked this question, sorry.
I think it's important to recognize when certain situations can influence your decision making. And that would be, so for example, I will never do a tricky procedure if I'm tired or thirsty. I'll sit down, have a cup of tea, have a little break, and then I'll go and do the tricky procedure. And I tell all our junior doctors the same thing. You know, before you're going into a tricky situation, make sure you're. And there's a psychologist called James Reason who writes about patient safety, and he talks about error wisdom on the front line for staff. Anyway, slightly unrelated. So going into a situation where you're going to treat a relative of a close colleague, you know possibly that colleague is going to come to you with their ideas, and that is going to, and you're going to do things you might not do because of them. And so what I do in that situation is I set the ground rules in advance. So if I ever have a doctor who's a patient or a relative who's a patient, I will say very clearly something like, look, I know you're a doctor, but in this situation, I am the doctor and you are the patient. I know you're a doctor, so I'm going to talk to you like a doctor. I won't talk to you like a normal person, but you need to understand that the patient's care is my responsibility. Sure, we can talk about it, but you are not the doctor in this situation. Does that make sense? So I try and say it in a nice way, but I try and be really clear that the doctor is not the doctor here. They're just being a relative, or they're being the patient. And actually, sometimes that has a really good impact because it makes them feel less stressed. It makes them feel they don't have to worry, makes them feel that I'm taking it seriously, I will involve them, but this is not their responsibility. And actually, there are some important professional boundaries. And you cannot be objective if you're treating a close relative yourself. So it's important for good decision making that there are those boundaries. And that's the kind of conversation that I have.
And another question which has come up from the panelists is, at this moment, is medical education incorporated into the curriculum of all countries for the junior doctors? And if not, do you think it should be definitely included in the curriculum for all countries for the junior doctors?
Clinical reasoning education, you mean?
Sorry.
Yeah.
Yeah, sorry. Clinical reasoning.
Well, that's a really good question, because it's not. So I'm in this group, Clinical Reasoning in Medical Education group, and there are 33 medical schools in the UK. We've got over half of them represented on our group. I know of only one medical school that has formally integrated clinical reasoning education into its curriculum. What we're trying to do is we're just finishing we've got a paper accepted with revisions, so we're just revising it. It's a consensus statement on the content of undergraduate clinical reasoning curricula, and what we've set out is this is the content that we think you should teach. If you are looking at things through a clinical reasoning lens, these are the things that are important, and also these are the teaching strategies that are most effective. So it's sort of in two parts. We hope to get that published, but there's no well, there was a survey done of US medical schools. It was published a few years ago, and again, the majority of US medical schools, there's no formal clinical curriculum. They cite lack of time and lack of faculty expertise. Our argument is that you don't need more time. It's just the way you teach has to have a slightly different emphasis. But then the issue then is that we need faculty and we need teachers who have the expertise and that clinical reasoning vocabulary. That would be a challenge.
And Dr. Cooper, if I may ask, if I want to teach my juniors about clinical reasoning, what are the textbooks or research articles should I go through, or should I read to them, or what would be my approach to them to be a good teacher and make them good doctors? What would be your advice on that?
So we have posted some resources on our CREAM website. So it's just creme.org.uk, because there's some good books. There's actually a really good book by the American College of Physicians. They do a teaching series, and there's one of their books is called Teaching Clinical Reasoning, and that's the ACP series. And so if you go to the CREAM website, we've listed some resources, some good papers, and some just introductory books. The ABC of clinical reasoning was written for medical students. So I wrote it for my medical students. I wrote it for people who don't know anything about clinical reasoning. We hope to do a second edition because I've learned a lot more since then. But that's a good introductory text as well. So yeah, try the CREAM website and have a look at the resources there.
Thank you very much, Dr. Cooper. I will do that.
And the other question which came up was, even if it's not formally included into the curriculum, are there any ways where, without it being included in the curriculum, medical students can still be taught to solve problems properly through more critical clinical reasoning?
Yeah, so the key to that is what's called deliberate practice, which is not just practice, but practice with effort. It's a specific thing described by Anders Ericsson. So deliberate practice is when so for example, you need to go and see as many patients as possible in as many different contexts as possible, and you need to practice problem representation, practice making a plan for the patient, and then you need feedback and coaching on your decision making and your plans. Be curious and ask questions, particularly in those different areas of clinical reasoning: evidence-based history and exam, interpreting diagnostic tests, the problem representation and management, identification and management, and the shared decision making. So get feedback in those specific areas.
There's been an interesting question from Dr. Ahmed Shams. So the question is basically, often how we feel towards our patients, our sympathy and empathy towards our patients, does that have an effect on our clinical reasoning, or what's your experience and what does research say about this?
That's a fantastic question. Absolutely, yes. And these have been termed affective biases, as in our affect, our mood. And there was a beautiful study on Dutch medical registrars where they were seeing simulated patients, some of whom were asked to exhibit difficult behaviours. And what they found was that when the patient exhibited difficult behaviours, the doctor was more likely to get the diagnosis wrong, significantly. And they put this down to the fact that their cognitive effort they had to put cognitive effort into the patient's behaviour. Example, I can't remember what it's called now, but how our feelings towards the patient can definitely impact on our decision making. We know physical problems are put down to their mental health problems, so there are these various biases at play. Yeah, definitely.
Would you then encourage our physicians to just treat the patients as patients and have no effective relation with patients, like effective judgment towards the patient?
Well, you see, sometimes the patient is extremely annoying, and it's very difficult. And what I've learned to do and step back from it. So I've learned to recognize, okay, this patient is really annoying me. I'm feeling this way. That's going to impact on my decision. And then I'll try to get the best information I can, and then sit down and think, what would I do in this situation if this patient wasn't like that? You know. So I try to be more reflective on the situation, because I know that I will just behave differently in certain situations. Yeah, we can't help feeling annoyed or you know.
What if it's the other spectrum of the emotion, where you have a trust with the patient over the years, whether it's a close relation with the patient.
Right. So that's a good question. There was actually a study published, and it was in the newspapers in the UK, and the headline was "Chummy oncologists are bad for your health," and that was based on a study where they asked new consultants in oncology. They asked them how friendly they were. So younger oncologists were much more likely to give out their mobile phone number, even be friends on Facebook with patients, which is bad, by the way. But what they found was that the more friendly they were with their patients, the less likely they were to be honest, the less likely they were to tell them that their illness was terminal and that the chemotherapy was not curative, and to help them plan for the end of their life. So yes, it does work the other way as well.
So I think for now we have all the questions. We have all the questions answered. So I'll ask Professor Dr. Titumia sir to share his valuable opinion regarding the whole clinical reasoning and the whole session. If that's all right, Sir Titumia sir.
Thank you, Latif Raihan Rahman, and my colleague Raihan Rabbani, and also all other panelists. And I'd like to thank the organizer, the Radiant Pharmaceuticals, and my heartfelt thanks and gratitude to the speaker, the Cooper. And we have shared many things, and this was a wonderful session, and especially while we are going for the interactions, in question answering sessions. And definitely decision making and clinical reasoning is one of the key in success of a clinician, of a physician, and especially with the internal medicine specialist, and is probably is facing this problem in day-to-day life. And as successful teachers, And good clinicians always is good in reasoning, clinical reasoning, and in decision making. But the things what we have learned from the Cooper's lectures, this is wonderful. We should be very much systematic and analytical. And the things which I have picked up from her lectures, I'm sure all of us will be benefited from her lectures. And the things I have picked up is that the problem representing for everyone, and especially for the trainees, is the key part. And I mean, making a patient presenting with some problem and some symptoms, and the trainee and the physicians must be think it as a problem representation. So to think the whole symptoms as a problem, and then to find out the ways to solve the problem. And this is very much important. And I think interpretations of the investigations, and especially the knowledge organizations about the interpretations of the findings of investigations with the problem, and also correlating the evidence-based clinical findings, probably will be very much helpful in decision making. And this will, if we exercise these in our clinical practice and in building up our trainees, I'm sure each of us will be benefited. And besides the clinical sharing also in some places will be very much helpful. One important and another important things what we should practice, and what she has mentioned very nicely, the probability of a disease and with interpretations of the investigation findings. I mean, this is very much interesting. Will be is one of the important things in making the proper clinical decision making, and also in taking the decisions. And definitely, though we have got some biasness, some intuition sometimes helps in shortening the times, we should avoid these sorts of exercises, the biasness, emotional affection with the patients, and also the practice of the, type 2 or system 1 in interpreting the symptoms and in making the decisions, because intuitions and the biasness make the errors in the diagnosis. So we should be very much systematic in analyzing and interpreting the symptoms, and also I think the problem representing the symptoms and signs should be sort out, or should figure out as a problem solving attitude. And all these things will be very much helpful for us in near future. And I'd like to thank again all the participants, and very nicely, the answers we have got from the speakers, especially the Coopers, and she was very much generous and very much relaxed in answering the questions, and still she can take more questions, seems to be. And I'm sure in the near future, we'll interact with her in another sessions. And again, I like to thank her on my behalf and on behalf of the doctors. We are in a forum, academic forum of acute medicine in Bangladesh. We are trying to building up a forum, and Professor Raihan has very nicely mentioned what is our purpose and how in near futures we are going to help our fellows and our clinicians in their trainees, and how we can build up a forum which will help a lot in making our physicians aware about the acute medicines, and to bring this into our clinical practice and in our medical education. Thank you all.
Thank you.
All right. Thank you, Dr. Titumia, sir, for your valued opinion and for your time. So for me, the last 2 hours went like a whisker. It was a fantastic 2 hours for me. I myself got to learn a lot from this session, and I express my heartfelt gratitude towards you, Dr. Cooper, towards Dr. Raihan Rabbani, sir, and towards Dr. Titumia, sir, for their valued time. I would also like to thank my fellow organizers, Dr. Shihan Haq and Dr. Anam, and all the panelists who actively took part in what I felt was a very interactive session. So I really enjoyed the way the session went on. Rather than being a one-way communication, I thought it was very interactive. And I hope that all the participants who participated in this session had their questions answered, and we got to know and learn quite a lot of things. I'd like to thank Radiant Pharmaceuticals, because I thought they did a fantastic job in making this session very smooth, because I've attended a lot of other online sessions which often get ruined due to a lack of smoothness in the way they're run. But I thought the transmission, the network, everything was very smooth. So a huge thanks to Radiant Pharmaceuticals for making this a very smooth and successful session. And the good news is the Academic Forum for Acute Care Physicians, in trying to play their role in helping to develop acute medicine in Bangladesh, is planning to hold future sessions like this. And Dr. Cooper has kindly agreed to giving her very valuable and very like precious time to us, the doctors of Bangladesh, and sharing her knowledge on a regular basis. So this is not the last of such sessions. This is hopefully the first of many future sessions to come. So again, a massive thanks to Dr. Cooper for like giving the doctors of Bangladesh to the opportunity to enjoy massively from your experience and knowledge. So with this, I would like to conclude the session. So again, a massive thanks to everyone who participated in this session and made this a successful one.